Welcome to the webinar, Shoulder Dystocia, Strategies to Improve Outcomes, featuring Dr. Henry Lerner.
Thank you. It's a pleasure to be able to speak with you today. My topic today is shoulder dystocia, and specifically the brand new document put out by the American College of Obstetricians and Gynecologists, which is a position statement on their view of where the science stands today about shoulder dystocia, about brachial plexus injury, and about the causes of brachial plexus injury. Now, if you've been involved in a shoulder dystocia case, you will know that plaintiff expert witnesses will claim that the only way that permanent brachial plexus injuries can occur is by excessive physician traction. And these same experts will claim that there are many reasons why this patient shouldn't have been allowed to go into labor in the first place. She was too heavy, or she had a history of a tough labor, or the baby felt big, whatever it is. Therefore, by the time the plaintiff lawyer is done speaking, the jury thinks that this was a disaster waiting to happen. The defendant should have known better, and because he or she didn't, a beautiful child has a lifelong injury. This often results in large awards because of the obvious damage to a child victim, and there's a seeming plausibility to the argument made by the plaintiff team that the obstetrician must have panicked and pulled too hard, or else this injury would not have occurred. Plus, it's hard to prove a negative. It's hard to prove the doctor didn't cause the injury. Well, how do we confront these claims? The answer is with the facts. With the knowledge of the anatomy and physiology and causation of shoulder dystocia and these injuries, we can refute false plaintiff claims. There is now a large body of literature that confirms the defense position in almost all the arguments involved in these cases. And ACOG has just summarized this information in a brand new document released about 10 days ago called Neonatal Brachial Plexus Palsy. Any of you who are listening who are involved in medical malpractice claims and risk management should go on the ACOG website. It's acog.org to get a copy of this, because it'll be invaluable to your lawyers, to your defendant physicians, to your risk managers in dealing with shoulder dystocia and brachial plexus injury. It was written by all the experts in the field. Every one of these authors listed here who was on the committee who wrote that has been the author of at least 10 or more articles on shoulder dystocia. The questions they examine are the key ones that come up in every case. Can one have predicted that there would have been a shoulder dystocia and injury? Could it have been prevented? Is all brachial plexus injury caused by exogenous forces, that is, by physician traction? And can brachial plexus injury occur without there having been a shoulder dystocia? But what causes shoulder dystocia? If you look at this illustration, you'll see that the baby's head is delivered, the obstetrician's hands are on the baby's head, but the shoulder is behind the pubic bone. Now, if the shoulder does not turn so that it slides underneath the pubic bone, the remainder of the baby will be stuck. And different maneuvers will have to be employed to try to get that shoulder out, or else in 4 to 5 minutes the baby will suffer lack of oxygen, brain death, cerebral palsy, and ultimately real death. One has to distinguish between anterior shoulder dystocia, which that previous picture illustrated, and posterior shoulder dystocia. Now, if you look at the posterior shoulder here, you can see it's caught on the sacrum, which is the pinkish area about half an inch to an inch just to the right of where the spinal cord ends. You can get a brachial plexus injury in the posterior shoulder by a posterior obstruction in this area. Now, anatomically, if you've been involved in these cases, you will have heard these terms. An Erb's palsy is when the upper nerves, that is the nerves coming out of the spinal segments C5 and C6 and C7, become stretched, torn, or injured. Klumpke's palsy, which happens more rarely, occurs when the lower roots are injured. And if you have a pan-brachial plexus injury, that means all of the roots are injured, and you even get injury of one of the nerves that controls the diaphragm and the face, so you can get eye droop and you can get difficulty breathing. You can see in this illustration how those nerves run directly under the shoulder and under the collarbone, the clavicle, so that if the shoulder and neck get stretched apart, those nerves come under stretch. You could also see in the illustration to the right the different muscles of the arm that are innervated by those nerves. So if the nerve gets damaged, those muscles get damaged, and that's what causes the ultimate injury to an arm in a brachial plexus nerve injury case. How do we define shoulder dystocia? Well, there are several different descriptions. The one that I think makes the most sense is that it's a delivery that requires additional obstetric maneuvers other than what you ordinarily do to get the shoulder out after delivery of the head. Some experts, such as Dr. Sponge, says that if it takes more than 60 seconds between the delivery of the head and the shoulder. An important item is that shoulder dystocia can only be diagnosed after delivery of the head. Now, that may sound obvious and trivial, but when you're in court, the plaintiff attorney will make it seem to the jury that shoulder dystocia was going to be obvious while the patient was pushing or at some other point. In fact, it's only after the head delivers and the shoulder does not follow immediately afterwards can you tell that you have a shoulder dystocia. How frequently do they occur? Well, shoulder dystocias occur roughly in 1% of all deliveries. And of the shoulder dystocias, you get about a 10% rate of brachial plexus injury. And of the brachial plexus injuries that can be temporary or permanent, you get about 10% that stay permanent. So adding up the numbers, the rate of shoulder dystocia delivery is 1%. The rate of brachial plexus injury when you have a shoulder dystocia is 10%, and the permanence of those injuries is 10%, which leaves you with a risk of permanent brachial plexus injury of 1 in 10,000 deliveries. So you have a unit that's delivering 3,000 babies a year, you're going to get a permanent injury about every 3 years. Do these injuries occur without shoulder dystocia? According to the plaintiff bar, no. According to ACOG, yes, they do, and ACOG has data behind their statement. Multiple studies have shown this. If you look at all the papers that have been published on shoulder dystocias, the rate of brachial plexus injuries where no shoulder dystocia was recorded varies from 1% to 50%. The rate of brachial plexus injuries that occur even at cesarean sections, where it's a lot easier to deliver a baby, is about 1 per 1,000 live births. So there is data showing that you can get a brachial plexus injury without a shoulder dystocia. Are there risk factors that you can use to predict when a shoulder dystocia will occur? This happens all the time in court. The plaintiff attorney will say, well, doctor, didn't you see this and didn't you see that, and don't you know that ultrasound estimations are 15% off, and why didn't you assume the baby would be big and this way the baby wouldn't have been injured? Well, you can't predict it. Here's why. If you have a baby with an estimated birth weight of 4,500 grams, that's 9 pounds, in a diabetic mother, so that's high risk, 9 pound suspected baby, diabetic mom, only 5%, 1 in 20, will have a brachial plexus injury. So that means if you did a C-section for all of them, you're doing 19 unnecessary C-sections. If you have a non-diabetic mother with a baby that big, the rate is only 2%. What about risk factors that you can use to predict when shoulder dystocia will occur? Well, no, because it's not only big babies of diabetic moms that have shoulder dystocias. In fact, about 50% of all shoulder dystocias occur in babies 8 pounds or less. Plus, if you try to estimate birth weight before delivery, it has been estimated that a physician's estimate and an ultrasound examination is no more accurate than the mom's guess as to what the baby weighs. And this has been demonstrated in 2 studies, that if the mom says, oh, this baby's bigger than my next one, I think it's going to be 9 pounds, she is just as likely to be accurate as the physician who's delivered thousands of babies. So estimating fetal weight is really tricky. You have a belly, you have fat in the belly, you have a uterus, you have amniotic fluid, you have a placenta. There's a lot of things that can throw off an estimate. Now, are there any risk factors that you can point your finger at? Well, there are 2. 1, increased birth weight, and 2, maternal diabetes. The problem is that increased birth weight is measured after the baby's born. You can do a study and look at all your shoulder dystocia and say, well, 50% had increased birth weight. But before the baby's born, can you correctly identify which babies are going to be big? And then, what is the chance, if you have a big baby, that it will in fact have a shoulder dystocia? If the chance is small, that 5% we talked about in the last slide, that means if you did a C-section for every baby you thought was over 9 pounds, you'd be doing many, many, many unnecessary cesarean sections. Now, there are some caveats with all this. You have to recognize that the mean birth weight of babies with shoulder dystocia isn't higher than the mean birth weight of all term babies. We talked about that half of all shoulder dystocias occur in babies 8 pounds or smaller. Many people have said, well, let's see, if we can deliver smaller babies, maybe we can avoid shoulder dystocia. So let's do an early induction. In fact, I have 2 junior partners who, even though I've showed them the literature time after time, continue to do this. They'll deliver a baby at 38 and a half weeks, below the 39-week cutoff we all know about. Their thinking is, well, if a baby gains 300 grams a week and we deliver the baby 2 weeks early, we can get a baby that's a pound and a half smaller. The problem is that there have been at least 4 studies that have shown that attempts to reduce the rate of shoulder dystocia by doing early inductions only increase the rate of cesarean section. It does not decrease the rate of shoulder dystocia. The predictive value is, if you say X is going to happen, how often are you right? So the predictive value of saying, I think this is a big baby likely to have a shoulder dystocia, well, unfortunately, the predictive value using conventional risk factors is only 16%. What that means is that your guess is wrong 84% of the time. That's why it's tough to tell ahead of time which babies are going to have shoulder dystocia. Now, this was a very, very important article published about 8 years ago by Rouse, who was at the time chairman of the University of Alabama's OB department. He showed in a very careful analysis that if you had a lady with 2 high-risk factors, that is, she was a gestational diabetic, and her estimated fetal weight for her baby was greater than 9 pounds, that 4,500 grams, you would have to do 443 cesarean sections to prevent 1 permanent brachial plexus injury. Now, who are these diabetic women with big babies? These are usually obese women. They may have other medical problems. So if you have to do 442 unnecessary cesarean sections for every brachial plexus injury you prevent, how much trauma and morbidity are you going to get in those 442 cesarean sections? How many of those women are going to have a wound dehiscence or develop pneumonia or have hemorrhage because it's difficult surgery in a very large abdomen? So the idea that you can do prophylactic cesarean sections to prevent shoulder dystocias is a very risky proposition. If you have a non-diabetic woman, you have to do 3,695 cesarean sections to prevent 1 permanent brachial plexus injury if you have a big baby. That's just prohibitive. We talked about this before, so I'll skip this slide. Now, fetal weight estimates are of limited utility because we're often wrong. We talked about estimations by doctors. Ultrasound examination and weight estimation is plus or minus 15 to 20%. So if you have a baby that the ultrasound tells you weighs 9 pounds, that baby can weigh 7.5 pounds, or it could weigh 10.25 pounds. And I've heard lawyers in court say, well, doctor, you had an 8-pound baby. Why didn't you add the 15% possible variability to it and see that that was a large baby and do a C-section? That's the ridiculous level to which these claims get in court. But it also shows that your estimate is very often not going to be accurate to a pretty large degree, 15%. Now, what does ACOG say? ACOG says in their bulletin on shoulder dystocia that you should consider a cesarean section if you have an estimated fetal weight of 5,000 grams, that's about 10 pounds, in a non-diabetic baby, or if you have a 4,500 gram estimate, 9 pounds, in a diabetic woman. Now, please note this. They say consider. In court, the plaintiff attorney, if you have a 9-pound baby after delivery, and you didn't know it was 9 pounds before delivery, that lawyer will say, well, didn't ACOG tell you that you should do a C-section with a baby this big? Well, number one, you didn't know it was going to be 9 pounds before delivery. And number two, ACOG says no such thing. ACOG says that a cesarean section should be considered prophylactically in this situation. What about having had a previous shoulder dystocia? Does this increase the risk of a repeat shoulder dystocia? Here the answer is clearly yes. The rate of recurrence of shoulder dystocia is between 10 and 15%. And if you had a baby that was injured the first time, the rate of injury is 3-fold higher with a second baby. So in my practice, and I'd say the majority of practices around the country, obstetricians will recommend a cesarean section to a woman who, in a previous vaginal delivery, had a shoulder dystocia. Okay, are all brachial plexus injuries related to clinical traction? Well, according to the plaintiff lawyers, of course. The doctor just panicked, pulled too hard. That's why this baby is injured for the rest of his or her life. Studies have demonstrated that both transient and permanent brachial plexus injuries in fetuses delivering vaginally have occurred without shoulder dystocia, and even in fetuses delivered by cesarean section without shoulder dystocia. So ACOG now, in this bulletin, is answering that claim by the plaintiff attorneys that all brachial plexus injuries are due to shoulder dystocia. And these are some of the facts they use to challenge that claim. What causes brachial plexus palsies? Well, there are two kinds of forces. Endogenous forces are those generated by the mom. Those are her uterine contractions and her maternal pushing. The birth process itself can stretch the brachial plexus. Now, take a look at the picture of the fetus here. You have the long axis of the fetus. The uterus and maternal pushing is applying force along that axis. What happens if right here the shoulder gets stuck? Well, the baby is being pushed down this way, but the shoulder is stuck. So where is there going to be stretch? It's going to be right over here, and that's where the brachial plexus nerves are. So just by maternal forces of pushing and uterine contractions, the baby will be pushed out, the shoulder is stuck, and the nerves in the neck, the brachial plexus nerves, will get stuck and stretched. Now, stretch results from this differential motion between the fetal head and the shoulders because the pubic bone blocks the progression of the shoulder. Well, why are some babies injured and some babies not in shoulder dystocias? One, because of biologic variation. Some babies have stronger brachial plexus nerves, have stronger muscles around the nerve that protect the baby. There can be differences in fetal size, in the tissue strength, but also if a baby before the shoulder dystocia has suffered hypoxia, that is, has a bad strip, the muscles will be more relaxed and will not offer as much protection. It's been shown that pound for pound, babies that have low APGAR scores after birth are more likely to have brachial plexus injuries from a shoulder dystocia than babies with a shoulder dystocia that have high APGAR scores after birth because the muscle tone around the nerves, protecting the nerves, is better. Now, if you get involved in these lawsuits, you'll see a lot of force studies. I won't spend a lot of time on that here, but just as a handy gauge, if you read some of the work by plaintiff attorneys Allen and Gerwich, they're out of Johns Hopkins. They testify as plaintiff expert witnesses in many, many trials. They will talk about different forces. 4 newtons equals 1 pound of force. That's a good rule of thumb. These are the two sorts of forces that are involved in labor by the mom, the uterine contractions and the mom's pushing effort. And the other force, which is invoked by the plaintiff attorneys, is that of the physician pulling on the baby's head. We know, and ACOG has said in this bulletin, that you don't have to invoke physician pulling to explain where the force of a brachial plexus nerve injury comes from. Maternal forces alone are an accepted cause of at least transient brachial plexus nerve injury. And everybody acknowledges that if the physician pulls too hard, they can injure the nerve in the baby's neck. That's not what's a question in most of these cases. The question is that the only way that the baby could have gotten injured? Well, looking at the nerve itself, what happens to the nerve itself? You can have two forces working on it, compression and traction. If you put an intrauterine pressure catheter into a uterus during labor, and you measure the force of the uterine contraction with a mom pushing, you often get forces as high as 142 to 160 newtons. And what do the plaintiff expert witnesses say is the force necessary to injure a brachial plexus nerve? Allen and Gerwich, excuse the poor penmanship here, say that you need 100 newtons of force to damage a nerve. So we see that the maternal forces are measured to be greater than this already. You don't have to invoke physician traction to explain why a nerve gets injured. The expert witnesses will often talk about axial traction. What does that mean? Well, axis, of course, is the main lie of the baby. And most of the time when we deliver a baby, we help the baby's shoulder come out by giving gentle traction along the axis I've just drawn. Babies do not spontaneously emerge. If they did, they'd fall on the floor. You usually have to help the shoulder come out, and that's what physicians do. What you don't want to do is pull the head way down, increasing the stretch on the nerves in the brachial plexus. But if you put gentle traction a few degrees off the axis in this sort of direction, that is how a baby is normally delivered. If you go more than 25 to 45 degrees, you do have a chance of increasing stretch on the brachial plexus nerves. Now, there is a theory called the tractor-trailer theory about how these injuries occur. We talked about that in the illustration a few slides before. If you have a truck going under a bridge, even if it's going very slowly, let's say this truck is going 5 miles an hour, and the cab, the head, gets under the bridge, but the shoulder, the trailer, hits the abutment. If the cab guns the engine, where is the pull going to be between the cab and the tractor? It's going to be right here. And this is the equivalent of the brachial plexus between the baby's head and the baby's body and shoulder. That's why during a shoulder dystocia, there is force between the head and the shoulder, as the uterine contractions continue to push the body down this way, but the shoulder can't move. There's also another force acting on the brachial plexus nerves. If you look right here, you will see that if the baby is being pushed downward, the nerves are going to press right against the symphysis pubis of the mom, the bone. We know that if you put forceps on a baby and the forceps are in the wrong position, it can compress the facial nerve, causing facial droop. You risk managers out there may have had lawsuits about that. The same thing can happen here. With that mom pushing 140 newtons, pushing the baby against that pubic bone, the nerves themselves can be compressed, causing damage. So we have two potential ways that the nerves can get damaged in a shoulder dystocia. One is by stretching them. The other is by compressing them. A third method is that as the head comes out and you apply gentle traction, there is some widening of the angle between the head and the body. Now, we often will hear plaintiffs claim that excessive force was used. When I'm doing a deposition or doing trial testimony, I won't let them use that word because it's not excessive. It's either routine force that you use with all deliveries, or it's extraordinary force, unusual force. Well, what's the difference between normal and abnormal traction? Nobody knows. First of all, nobody has been able to quantify the amount of force used at a live delivery. Nobody is going to stick pressure sensors into the neck of a living baby to measure force during a delivery. So that data just does not exist. Data has been collected on models made of plastic and wire about the forces that appear to be there, but those just are different than the flesh of a living baby with muscular support, cartilage support, and living nerves. Well, I'm going to repeat this question which we talked about before. Do brachial plexus injuries occur without shoulder dystocia? Why is this so important? This is important because there are multiple cases where the obstetrician, a very experienced obstetrician, will do a delivery, the delivery goes well, there's no shoulder dystocia, there is a brachial plexus injury, and the plaintiff and the plaintiff expert witnesses will say there had to have been a shoulder dystocia, you didn't see it, you didn't recognize it, you can't get this injury without a shoulder dystocia. Well, that's not true. Jeanette, Uzonian, Gehrman have challenged that in published articles. Allen and Gurwitch themselves, the plaintiff medical experts, published an article showing a transient brachial plexus injury in a baby that was delivered without shoulder dystocia or physician force. But they said, well, it only applies to temporary injuries. Any injury strong enough to cause a permanent brachial plexus injury had to have been accompanied by excessive physician traction. Well, that's not true. 7 years ago, I was asked to review a case in Florida where a very experienced doctor delivered a baby. The baby came out in one push from being totally inside to totally outside. The shoulder was not stuck. The delivery took place in 2 seconds. There was no physician traction, and this baby had a permanent brachial plexus injury. We have a video of that case. So here's a case where there was no shoulder dystocia and no physician traction, and there was a permanent brachial plexus injury. This is the article I published about that. So Allen and Gurwitch had claimed that you can get temporary brachial plexus injuries, but not permanent. Well, we've proven it can happen. This is an important statement in that new ACOG bulletin. There is insufficient scientific evidence to support a clear division between the causative factors of transient versus permanent brachial plexus injury. So no longer can you get an expert witness come into court and say, oh, you had a permanent injury, it had to have been physician traction. This ACOG document, based on the evidence they've collected, says that that's not the case. We talked about posterior brachial plexus injury when the baby's shoulder gets caught in the sacrum, but I'll go over that for now because that actually happens in a very small minority of cases. We talked about force levels, how they're not validated. You can't really measure a physician's grip on a baby. Some people have tried to put pressure-sensing gloves on an obstetrician delivering a baby, but the pressure points are very limited. In most of the published studies, the pressure points were only on one glove on one hand, and I don't know of any obstetrician that deliver a baby with one hand. Usually they use two. So the data just is not very convincing. There are cadaver studies which are often quoted to show that, well, we know exactly how much force it takes to tear a nerve because we've taken fetuses that have died and we've dissected their brachial plexus nerves and we've put weights on the nerves and we see at what point the nerve snaps. But as ACOG says, the relationship between the in vivo, that is live baby occurrence of brachial plexus injury, and the in vitro, the laboratory experiments on cadavers, is purely speculative. Dead nerves do not have nearly the tensile strength that a baby has with live nerves surrounded by living muscle, surrounded by cartilage, surrounded by fat, surrounded by skin. So these cadaver studies that are used to show how much force was used and a physician used more than that force do not bear scrutiny. The bottom, I think, is a very, very cogent point in this direction. Nerve tissue deteriorates quickly post-mortem, making cadaver studies problematic. Now, we talked about endogenous forces, maternal pushing and contractions, and exogenous forces, those that the doctor applies when he or she pulls on the baby at delivery. Well, the forces at the fetal neck against the maternal symphysis pubis from these maternal forces have been proven to be 2 times higher than the clinician-applied forces. So let me state that in different language because it's a vitally important point. It's claimed with brachial plexus injuries that obstetricians cause most of the damage. Yet studies have shown, Gonick and others, and these are summarized in this ACOG report, that the maternal forces, the uterine contractions and the mom's pushing, are 2 times stronger than the forces a clinician applies. How about the sequence of delivery maneuvers? As any of you who've worked with shoulder dystocias know, there are 4 or 5 maneuvers that are routine. You're supposed to go from one to the other. You're supposed to implement them promptly. If one fails, you go to the next, and that's a sign of a well-trained obstetrician doing everything right. Well, It has been shown conclusively that no one sequence of maneuvers is better than any other. So you can put the legs back in a McRoberts position. You could press down above the symphysis pubis and give suprapubic pressure. You can do this rotation, a Rubens maneuver, or you can grab the posterior arm and bring it out. Those are the four basic maneuvers, and it doesn't matter in what order you do them. What about episiotomies? I've seen physicians that have been criticized because they didn't do an episiotomy in their attempt to resolve a shoulder dystocia. It turns out that you only need to do an episiotomy if you need more room to put your hand inside to move an arm. If you have sufficient room to insert your hand, it's been shown that episiotomies do not aid in resolving the shoulder dystocia. The Zavanelli maneuver is a rarely used maneuver that is much more often talked about than performed. I've heard plaintiff lawyers say, well, your first maneuvers didn't work, doctor. You're 4 minutes into your shoulder dystocia. Why didn't you do a Zavanelli maneuver? Number one, it takes a long time to do a Zavanelli. You have to push the baby's head back into the pelvis. You have to get to the operating room and do a cesarean section. By the time you realize that your maneuvers aren't working, you're already 4 or 5 minutes into your shoulder dystocia. The baby's already hypoxic. And then you're supposed to go back to an operating room and spend another 5, 10, 15 minutes doing the operation, getting things set up. And by that time, the baby's 20, 25 minutes into the shoulder dystocia. Those babies don't survive. Moreover, it's been shown that the maneuvers of pushing the baby's head back inside fracture the spinal cord, cause cerebral palsy, and cause all sorts of brain and body morbidity to the fetus. Plus, there's a risk to the mother of a stat cesarean section. An interesting question is, how much time do you have to deliver a baby safely before neurologic damage comes in due to the baby not getting enough oxygen? Various numbers have been bandied around the last 20 years, anywhere from 3 minutes to 8 minutes. But 2 studies recently have pretty much nailed this down. Liang in a hospital in Hong Kong showed that you have up to about 5 minutes before there is a significant increase in the risk of lack of oxygen to the baby causing brain damage. So obstetricians do have a certain amount of time to do the maneuvers. And when I teach obstetricians about shoulder dystocia maneuvers, we talk about this. They don't have to get everything done within 1 minute. They have time. They don't have to panic. As long as they have somebody in the room calling out to them every 30 seconds that goes by, doctor, you're 2 minutes in, doctor, you're 2.5 minutes in, so they know how far they are, they can take their time and do the maneuvers they were trained to do. The problem is that when you're in the middle of a shoulder dystocia, you don't know that you're going to get the baby out in 3.5 minutes. You're working and you're thinking, this baby is stuck. This baby may die. This baby may have a brachial plexus injury. And I'm here and I don't know if my maneuvers are going to work. So to say, oh, doctor, you got the baby out in 2 minutes, you must have rushed and panicked and pulled too hard. Well, that doesn't account for the fact that when the baby was stuck, when the doctor was working, he or she did not know that the baby was going to come out right then. It could have been another 2 minutes or another 2 minutes after that. I did a study with Dr. Emily Hamilton from Montreal where we looked at 110 of the shoulder dystocia cases I had helped defend. And we saw that if you look at 2 kinds of injury, neurologic injury of the brain and the brachial plexus injuries, that after 4 minutes, no baby was born without either one or the other. So in my teaching, I say you have basically 4 minutes to get the baby out. What do you do after that? Well, then you're at liberty to pull harder. And even plaintiff expert witnesses and lawyers will acknowledge that once you hit the 4 to 5 minute mark, if you use a lot of force, that's okay because otherwise you might have a dead baby. How do you prepare for shoulder dystocias? Well, simulation and team training is our best tool. Any event that does not occur frequently is difficult to keep one's skills up in, and this applies especially to smaller hospitals. A smaller hospital may only have 1 or 2 severe shoulder dystocias every year. And if you're 11 months away or 2 years away from your last shoulder dystocia, you may not remember or be as skillful as you should be in how best to resolve it. So drills are the best way to practice. And you can do it with very high-tech equipment like the $30,000 Noel, or you can do it with a baby doll and a box with a hole in it. And you can practice all the maneuvers, and you can work the drill, and you can have teaching sessions with a $15 setup or a $30,000 setup. I find that it's best to do drills on your own unit. Simulation centers are wonderful, but often in those centers, you're not where you're going to be delivering a baby. You're not in your own unit. You're not working with the people you're going to work with in an emergency, and the sim centers are very expensive. If you have one, by all means, make use of it. If you don't, you can do these drills just as easily in a labor and delivery bed using a baby doll and any box with a hole in it. Now, the ACOG document that this is summarizing, this whole talk is summarizing, is called Neonatal Brachial Plexus Palsy, makes multiple definitive statements that counteract false and dubious claims made by the plaintiff bar in these brachial plexus cases. They disprove the claim that excessive physician traction is the only etiology of brachial plexus injuries. They demonstrate that you can't differentiate between permanent and temporary injuries when you're talking about the amount of force a physician applied. And it shows how brachial plexus injuries can occur even in the absence of physician traction or even shoulder dystocia. This ACOG summary provides a summary of the current scientific information about brachial plexus injuries, and it's going to benefit all obstetrical clinicians, both in terms of how they practice and in terms of how they defend themselves when claims are made that they did not practice well. ACOG has done a fabulous job in producing this well-researched, evidence-based compendium. Some of you may remember the green book that came out about 8 years ago about fetal neurologic injury. The green book became a similar standard that could be used in court to show what was good care and what was not good care. This ACOG summary is going to occupy that same role, and it's going to help obstetricians, hospitals, risk managers, and insurance companies ward off some of the scourge of plaintiff attorneys in shoulder dystocia suits. I've tried to make this presentation, while clinical enough to give you background as to the medicine involved, more involved in the arguments and questions that come up when shoulder dystocia cases and issues come before risk managers, insurance companies, etc. I hope it was not too technical. I invite questions, and I look forward to having a conversation about these various points that were discussed with you all.